All right, here we go. Episode number 18 of the GBNO show, the Get Better Not Older show. I am Dr. Rob Jones. This is my awesome wife, Shannon, the dietitian.
Hi.
You notice how I didn't say hi, Shannon?
I did notice.
Yeah, I wore that joke out. So if you've been following us or following me online, you know I am the outside-in guy because I am a musculoskeletal medicine. Not really medicine, but a musculoskeletal expert, if you will. And Shannon is the inside-out girl because she is a...
nutrition expert.
Yeah, dietitian. Don't sell yourself short. Clinical dietitian. Difference between a nutritionist. A lot of people don't know that, but a nutritionist is one who can get a weekend education, call themselves a nutritionist. You're a dietitian. You took many, many years of university. You wrote board exams. You're state and domestically, federally certified through a board. So there's a bit of a difference. And you worked in a hospital in a clinical setting. So that's why I like to say clinical dietitian, because it just takes a little bit more education. So There's my kudos to you. Okay, so I'm the outside in, she's the inside out. And Shannon's been talking a lot lately about inside out stuff. I'm going to take over this one, because I love to hear myself talk. And Shannon loves that too, right? Mm-hmm. But I think this is an important topic because really what we've been seeing in medicine, and I really think it's been going on for quite a while, but it's really taken hold in the last 5, 8, 10 years. And this is really, when I came out of school in the early 2000s, 2001, there was an art to diagnosis. We were taught something at my school up in Canada called differential diagnosis, and my school was big on it, and I think it's really helped me clinically to be an accurate clinician, and that is somebody presents to you, okay? In my world, let's say it's a low back problem. So you put in a basket everything possible that can do with the lower back. Is it a tumor? Is it a skin growth? Is it a bone problem? Is it a muscle problem? Is it a cartilage problem? Is it an infection? And as you go through your history and examination, which takes time, you start to pull out the things that,
rule them out.
You just rule them out. Okay, so the person's not having night sweats and you have a clear x-ray and MRI, then we know it's not cancer. The skin looks fine. It's not red and hot and swollen and they don't have a fever. We know it's not an infection. So you rule it down based on these criteria. And to me, that there's an art to that. And it takes not only skill and experience, but it takes observation and time. And I think time is the biggest thing we're losing in healthcare right now because we're seeing all these huge corporations, hospitals, et cetera, buying up clinics, and they're holding the doctors accountable for the amount of volume they're seeing while they're treating patients. So if you don't reach the incentive of seeing 30 patients a day at 10 to 15 minutes each, billing out X, Y, Z, the reimbursement isn't going to be there, so you're not going to get paid out as much. I'm not saying it's anything nefarious at all, because I know there's a ton of good doctors out there, but they're just doing what they have to do to make a living.
Managed care like this has been going on. I mean, it really took hold after I returned from Canada. I remember when I went up to live with you while you finished school, my mind was blown with socialized medicine, one.
That's a whole
and I always
topic.
Thought managed care was absolutely horrible. I always felt like we were going down the rabbit hole of just terrible quality of care. That is what I always felt. Then I experienced socialized medicine, and I don't think it gets any worse than that.
Yeah, as I said, that's a whole topic.
Everybody
for another
thinks
day.
We want that.
No,
I have
don't.
news for you. We do not.
No, we don't.
I experienced both, worked in both, and I assure you it is not what we want.
Yeah.
So I digress, but my point is that is right when HCA and all of those managed care groups were taking over.
I need a timeout. Explain what managed care is.
It's exactly what you just said, where there are groups buying out doctors instead of it being under the hospital. Or let's say a group of doctors get together and say, let's just locally own our own clinic and have rights to the local hospital. it is a company coming in and buying up all the doctors and then also buying up some of the hospitals too.
Right.
And so then that is what we call managed care. And it's, you know, it's clearly a business as it needs to be. But the biggest thing I noticed was the quality of care. I feel like significantly has gone down, as you said, because they have to meet this criteria of seeing so many. I mean, I can't even tell you how many doctors that I have heard, or mid-levels, which are your nurse practitioners and your PAs, who get into it thinking that they're actually going to have time with the patients, and it's not. It's just, it's like a, you know, herd them through. It's, you know, and that they don't even have time to. A lot of the doctors who have gotten out of that field, the Western medicine field, and gotten more into functional medicine, it's because they were tired of being told how to practice based on insurance reimbursement.
Right.
And that's the sad thing.
And that's what we've done here. Since our move to Florida, I'm no longer accepting insurance. And I used to follow the 30-minute, 15-minute model for a new patient back in Kansas, and I had an extremely busy clinic. I was booked out weeks on end, every 15 minutes, every single day, unless it was 30 minutes for a reevaluation and a new patient, which is an eternity. Most people, even with a new patient, doing what I do, or on the medical side, 30 minutes, I can't tell you how many practitioners go, you got to cut that down. I mean, you're not going to be able to see enough people. And to me, that was minimum of what I needed to see, because I had to take a thorough history, I had to do a thorough exam, and then treat on the same day. And a lot of people won't do that in my world. Now, medical doctors will, especially if it's sick care.
But also, you do not practice like a chiropractor. Like, I mean, you're not in just crack, 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 and then sending them out. I mean, there was actually, I remember when you first started practicing that somebody tried to get you to go to some seminar where they were teaching you how to herd the patients through and like get them in and out of your office in 5 minutes.
Yeah, I walked out of the seminar. It was a really close friend of mine, who I won't mention his name, very successful, very good chiropractor, but the model was not for me. I went down to San Antonio from we were in Kansas, and it was a 2 or 3 day seminar. I left after the first morning because one of the speakers literally said, and I'm paraphrasing, but it was basically this: if your patient tries to tell you about their fishing trip or their kid's baseball game or whatever else, it's not about that patient. It's about how many people you have in the waiting room. So they had hand signals and gestures to basically get people to shut up. Well,
I remember you said it was like you throw the paper away, and the garbage can is by the door, and you start to reach for the door, which signals to the patient time's up.
Yes.
It was like this whole corny process that you were like, nope, this is not how I'm going to practice.
Well, because my undergraduates in exercise physiology, kinesiology, and athletic training. So I was used to rehabbing patients, like working with somebody for 20, 30 minutes on exercise. Yeah, doing adjustments and doing active release and stretching and all that, but doing active care where the patient is actually active doing work. And if you look at the research, specifically with lower back, the best outcome for lower backs, regardless of what type of lower back problem it is some sort of passive care, an adjustment, muscle work, whatever, and then an active component. Without the active component, healing times are way longer. And I just looked at that going, I want to make money to support my family, but to me, that's not quality of care. Now, again, not trying to knock it. It's just my comfort zone. Okay, I can't do that because it's just not me. I want to spend more time with people, and I want to fix them in a way that's comfortable with me and what my expertise is. Now, there's a lot of people that get help with that, but it's just not for me. But I want to go back to something for a second, and that is the managed care model, and that is basically, again, I'm not against for-profit medicine. Okay. We do that. That's what I do. That's what you do. We're making our living off of helping people, but we're doing it in a way that is in our comfort zone, which is fine. And again, I'm not trying to tell people not to do certain things. If they want to go to a doctor and they like that doctor and they spend 2 minutes with them or 5 minutes or 15 minutes, great. Do that. I'm just telling you from my perspective, and I'm in my 26th year, I don't think you can get completely healed with that short amount of time.
Well,
That's
can
all I'm
I
saying.
tell you something, that being married to you in those total of, well, more than 26 years.
26 long, long years.
Well, not really married that many years, but with you, hearing you come home and talk about all the misdiagnoses and the like just people who missed things and have been getting improper care for 6 months up to a year,
Yep.
and that they were in your office and you figured it out on the first visit. I can't even tell you. Well, I will tell you. It is you lately have been complaining about it more than ever.
Yeah.
But you historically have always complained about you're in disbelief that whether it be doctors or physical therapists or orthopedists or whatever are missing such simple diagnosis when it comes to.
Do you remember what I told you over dinner last night? We don't ever talk about names, okay, because it's HIPAA non-compliant. But remember what I told you last night? I had a patient that I've been treating on and off for probably 6 months, and I don't have staff anymore like I did back in Kansas. I book my own appointments. People text me, and she texted me, and she said, I'm in a really bad way. I need you to see me. I've strained my glute. And I said, no problem, I can fit you in. So I fit her in yesterday, and I said, how did you strain your glute? And she said, I don't know, but I went to my massage therapist, and she diagnosed me with a strained glute. Right away, there's a red flag, because nowhere in massage therapy training are they taught or allowed to diagnose.
Exactly.
Okay.
Stay in your lane, people.
So that's number one. And again, not knocking massage therapists. I know.
No, but they need to know that part of this is that we've got coaches who are diagnosing. We've got people who do not have diagnostic training are putting these thoughts in people's heads.
That's the problem.
And then it gets worse with Dr. Google.
Yep.
And then they pigeonhole their diagnosis, and
So this is a great segue. So this leads in, well, let me finish the story, and then what my friend, well, you know Lisa back in Kansas, shout out to Lisa if she's listening, she used to call them fairy stories, where people would come into her and say, oh, my massage therapist told me I had XYZ. And she would look at me and go, is that true? And I'd say, well, send them over. Let me look at them. And again, not that I'm any smarter than the next person, but I'm trained to do this. Massage therapist, again, be careful. If you're going to a massage therapist and they make you feel great, keep going to them. I'm not saying don't go to them, but I'm saying they're not trained to diagnose. So back to this patient. If you have a strain to a muscle, more times than not, 99.9% of the time, there's an incident that happens, okay? You're running, you're walking, you fall, and you go, oh, man, I just strained something. She had no incident. And the telltale was she had this aching, radiating pain in her buttock that went down to her mid-hamstring that only occurred when she sat. Sciatica. Okay?
And I'm not trained to diagnose,
exactly.
but I know that.
You just heard me talk about it forever. Here's the thing, folks. If you have pain when you sit, that is an aching in your back, aching in your butt, aching into your hamstring or down your leg. When you're driving, when you're sitting on your couch, when you're sitting at work, and you get up and you walk around and it goes away, that is 99.9% of the time a problem with the lower back, most likely a disc, pushing on the sciatic nerve or pushing on a nerve, creating sciatica. So I examined her when she came in. And I told her that, but she was convinced she had a glute strain. She argued with me. Not argue, but she was like, but I was told I have a glute strain. And I said, I understand that. Let's go through the testing. I glute max tested her, okay, under hard resistance because she's pretty strong. I glute medius tested her. I glute minimus tested her. I piriformis tested her. Everything in that area I tested. And if there was a glute strain, it would have been painful on activation. She had no pain. And then I did some ameliorative, easy for me to say, or fixing stuff exercise. That's a better way in the layman's terms to say it. And her pain went away. So that tells me it was out of the lower back. So again, this is what happens when we are symptom-focused, not cause-focused. This is another thing. The massage therapist has a cold laser, and she put cold laser on her glute where she thought it was strained. and said it was a strain. Now, the cold laser is not going to do any damage. All the laser does is it basically puts a light in the area and it increases cellular function. That's all it does. So you get like DNA replication and more cellular synthesis and all that.
But did that cost her to have that cold therapy?
Yes, absolutely. It was like another $25 on top of the treatment. So again, we're looking at symptom instead of cause. So when I went into the further discussion with her, I said, was there an incident? She goes, the only thing I can think of is we've got a huge yard and we spent 2 days picking up sticks and leaves after we pruned. There you go.
She was rounding her spine.
She was rounding her spine, and repeated flexion we know causes lower back issues. So she told me her diagnosis, okay, because I took the time to ask her questions because I allow enough time with my patients. So this is leading me into the whole symptom thing. We are this symptom-based diagnostic society right now, and it drives me mad, okay? There's a lot of people like me, and I've learned from some great ones. And if people want to know who those great ones are in different cities, message me and I will tell you, because I'm not the smartest guy out there. I'm just pretty good at putting myself in front of the smart people and taking what they say and melding it into my style of practice. Because I'm not the smartest guy around. I'll tell you that right now, and I'm sure you can corroborate that.
I actually disagree with you. You're one of the smartest guys I know.
I thank you, love you, but I think I'm just decent at what I do because I've been doing it for so
No,
long.
I always say this. You're not decent. You're amazing at what you do, and you're doing what you were put on this earth to do.
Thank you.
I mean, everybody has always heard of these amazing doctors. They're, whether they're out in Beverly Hills or wherever they're whatever, somebody has to be their wife or spouse. I just happen to be your spouse. So people will say, oh, well, it's because she's married to him. I can guarantee you every single one of your patients who you've helped would tell you, because they call you the miracle worker, you 100%, because you take the time and you're smart and you know what you're doing, you have the ability to help a large percentage of your patients. Have you missed some diagnosis?
Sure.
Every doctor does.
Yep.
But I would say, how many messes have you cleaned up?
A lot.
To help people who couldn't find help for years other places.
A lot.
So that means you're really good at what you're doing. You love what you're doing, and you're doing what you were put on this earth to do.
Thank you.
Now let's move forward.
All right. Checks in the mail.
Okay.
That was good, right, Eric? Young Eric is laughing at that. And anytime I get a laugh, I'm happy because I think I'm funny, but Shannon doesn't. So I digress. Okay. So we are a symptom-based system right now. Okay. And I want to talk about some of the symptoms that people are being labeled with, and then they pigeonhole themselves into this diagnosis, if you will, which I call more a label than a diagnosis, and then they think it's over. I've got arthritis.
Talk real quick about where the majority of these diagnoses are coming from?
Everywhere. I mean, think about the explanation the example I just gave you. Massage therapists are diagnosing people.
Okay, so I would say historically over the years, massage therapists have been a culprit a lot of the times.
Yes.
Yoga instructors have been a culprit, or exercise class instructors have been culprits a lot.
Instead of the yoga instructor going, oh, you hurt there during that move, you should go see somebody. What I'm seeing a lot back in Kansas, in Toronto, and here, and I'm sorry, I'm not trying to throw anybody under the bus, but you got to stay in your lane, okay? Mm-hmm. I can't do orthopedic surgery, so I don't tell people I can, but I am licensed to diagnose, okay, in a couple different countries and a couple different states, so I can say this firmly that if somebody comes in, I can figure it out. If I can't, I'm going to send them elsewhere. I'm not going to say, oh yeah, that's your sacrum is rotated, or you have, this is what I get a lot. My back hurts. I was told one leg is longer than the other, or one leg is shorter than the other. And that is a symptom, not a cause. Yes, you can have something called an anatomical short leg, which can cause some symptoms, but more often than not, unless you're having to wear one of those big elevated shoes because you had like a growth abnormality in utero, those are symptoms, and those instructors should be going, oh yeah, you hurt there, I got a good person to go see, or go see your doctor, or go see whatever.
The message here is, it's really interesting because in the medical field, we are taught to refer.
Yes.
If you cannot properly diagnose and properly manage a patient, and it's not in your lane, scope of practice, then you refer out.
Yeah.
It's interesting how other, massage therapists who, they're not professionals. They didn't get, they don't have a professional association that's watching what they do.
You're going to make some people mad here. Because they get certifications and they have to be recertified.
Certification is a whole different thing than being held to not being able to practice because you're board certified because you're practicing outside your scope.
100%.
This is the problem, that they're practicing outside their scope, and they need to be able to say, "Ooh, I'm so sorry you're hurting there. I sure hope something you've done, did in this class did not cause that, but I suggest you go see so-and-so. He's really good, or she's really good."
Yeah, 100%.
And having a referral pattern instead of trying to diagnose people that you have no credibility to diagnose.
Well, and this is what happens, and I can't tell you how many times, literally hundreds of times, people coming in going, "Oh, my Pilates instructor told me my back is my sacrum, or my back is my pelvis." And because the location is where it is, it's maybe right there where your sacrum is, which is that upside down triangular bone in the small of your back that you kind of almost sit on. But instead of going, it hurts there, I don't know what that is, it's almost like you're trying to enter this realm of clinician without being clinical. So again, I don't want to beat the dead horse there, but it's happening in the medical field as well, and people are being labeled. And I want this to be really an eye opener for people, because I want them to stop thinking of their diagnosis as their label. Okay. And let me shoot a couple at you here. Okay. So you have headaches, you have a migraine. Okay. Here's what I know is not happening very often. And even at orthopedic offices, nobody's putting their hands on patients anymore. If somebody comes to me with migraines, because I'm trained to be a spine guy and a muscle guy, I look at the joints of the spine and I look at the surrounding muscles. There are referral patterns that are called trigger points. And, there's been books and there's studies, and we know this is a thing. I can't tell you how many times people have come to me and said, "Oh, I have migraines." And I palpate the back of their neck, their suboccipitals, which are right here, and it refers over into their temple or over into their ocular area, their eye area. And they go, "Oh yeah, that's my headache." Okay, well, so you don't have migraines.
I was going to say, that's not a migraine.
You have a tension headache. Okay, but also, people are chronically dehydrated. And a lot of times, if you just hydrate properly
or nourish properly,
guess what? Your headaches are going to go away. I had a guy back in Kansas who was drinking like 8 Dr. Peppers a day. And funny, right? Not funny, but not funny. And he was wondering why he was getting headaches. He didn't drink water ever. He woke up every morning, had a Dr. Pepper. He would have another one midday, have one at lunch, another one mid-afternoon, one with dinner, one in the evening. I don't know.
That's pretty extreme.
Oh, crazy. But of course you got headaches. You're not giving your body anything other than sugar, caffeine, crash, sugar, caffeine, crash, sugar, caffeine, crash. So if you have a migraine or a headache, go to somebody who's going to palpate you and not just look at you and go, "Oh, headaches, okay."
And also
ibuprofen, Max Salt, or whatever the drug is.
Also, not just go to somebody that go, "Oh, you just need to be adjusted 3 times a week for the next 6 years."
Yeah, well,
that's another issue.
I don't want to rag on my profession, but that's a whole nother podcast. I know. Sad that I have to say that to a lot of patients, because I hate this, and to the other chiros that are listening out there, we have this stigma, and I know it's not nefarious. I know a lot of chiros that are awesome, and they believe in adjustments a lot. But to me, because I'm a symptom guy, if you are getting adjusted 3 times a week for a month and you are no better, you don't need that adjustment for pain. If it was going to work, it was going to work in the first couple of treatments. Okay. But okay, I digress. So let's move down the chain. So now we've been labeled as, "Oh, we have migraines." That's the symptom. Where's the cause? Is it a muscle issue? Is it a joint issue? Is it a food or hydration issue? That's number one. You're going to say something?
Yeah, I mean, I'm just going to say, but that's where it stops in a medical office.
100%.
They are not asking, well, what are your symptoms? When does it happen? Or doing, it's just like, let's see, let me get out my prescription pad and let me get you something for,
And follow up in 6 weeks. And if it doesn't go away, we start thinking intracranial. That's what I see pattern-wise. So what do? They get a brain MRI, or they get a CT MRI to make sure they're ruling out tumors, which pretty damn good to rule out as a tumor. But again, you can save the system thousands of dollars just by if somebody comes in with a migraine, okay, and I take them through a range of motion and I palpate their neck and I can't find anything provocative and recreate the symptoms, okay, that's going to be a little concerning. So I'm going to say, okay, here's what I want you to do. I want you to hydrate with electrolytes. I want you to watch your diet, and I want you to come back in a week. If that doesn't change at that point, then I may think of something nefarious or something dangerous going on, okay?
But that's when they're doing that, they're going for the biggest thing first that is going to get them in trouble with malpractice or liability. That is why their brain, that's why they're having to do
100%,
that.
because God forbid you would not want to miss a tumor and have somebody pass. And then obviously that's the most important thing, but also you don't want to get sued.
Yeah.
Okay, so let's move down the chain a little bit to the neck. Can't tell you how many people come in with neck problems and they're chronic in nature. They never get better. They get adjusted, they get massages, and they feel better for a day or two, and then it comes right back. And I say to them, has anybody ever talked to you about your neck position? And I don't know if the camera's on me right now, but, you know, they're like this with this anterior head carried position where their neck is just jutting forward, where the chin is jutting forward.
And then wait, you're missing it. Now look down and look at your phone.
Oh, yeah. And then of course they're here all day. But you see all these elderly people, especially walking around here in Florida, where the shoulders are here and the head is like 6 inches ahead. And it's
turtles.
like, no wonder your neck hurts. So what do? They go and they get an x-ray and they go, oh, you've got degenerative disc disease, which is not a disease, people. It's a symptom of what you're doing with your spine and your posture. You get stronger and you build your anterior stabilizers to bring your head back. And then you do some thoracic work, because guess what? When you turn your head, you need your upper thoracic spine, which is where your collar of your shirt is, down to not quite your shoulder blades, to finish ranges of motion in your neck. If you don't move there because your head is stuck forward, guess what?
It stays stuck forward.
You're going to get pain. So a lot of times with the neck, it's stabilization exercises, mobilize the thoracic spine. And even if there's degenerative change, who cares? If your function is better, I don't care what your x-ray or MRI says. I can't tell you how many people come in and they've gone to their medical doctor. Medical doctors, again, not knocking anybody, okay? I'm just speaking factual. There was a study done at the University of Hawaii, and it actually took clinical interns at my old school up in Toronto. And then I believe these were fourth-year residents at I think it was the University of Hawaii. But they gave them a test, and it was a musculoskeletal test. There was close to a 60% failure rate on the medical side on these musculoskeletal tests, and an over 95% accuracy rate, thank you, on the chiropractic side. We're trained in musculoskeletal medicine, okay? The medical doctors get very little musculoskeletal medicine. They get taught to recognize, ooh, that may be a shoulder issue, better refer them to ortho, okay? So you go into your medical doctor, and you go, oh, hey, doc, I fell off the ladder, or, you know, I've been doing a lot of painting, or I've been playing some weekend warrior tennis, and now my shoulder hurts. Oh, you have a rotator cuff problem. Without doing any testing, without putting their hands on the patient, and they say, we better get an MRI, or we better send you to the orthopedist. And some of the good ones will say, oh, it's probably just, you know, a little shoulder strain or something. Let's send you to somebody like Rob or to a physical therapist or whatever, and they can get properly worked on and feel better. But more often than not, the medical doctor goes, ooh, that's musculoskeletal. That's out of my purview. Send them to ortho. So what they do is they go to ortho, and They often see a mid-level, which is a PA or a nurse practitioner. They don't even see the orthopedist because they're super busy. Unless it's a surgical case, then they'll see the orthopedist. I can't tell you how many times people are going to the mid-levels and even going to the orthos, and they don't put their hands on them and test them. They X-ray them, they MRI them, and then they look at the scan and go, aha, right here, you've got a partial tear in your supraspinatus. We better inject it. We better whatever it. We better do surgery on it, instead of going, okay, you got a little tear in your supraspinatus, but most people at your age, over 40, over 50, do anyways. Why do you have a little tear in your supraspinatus? Is it because your infraspinatus is weak and it can't stabilize the shoulder? Is your scapula not moving right, which is your shoulder blade, because your traps are weak? Is your serratus anterior not firing, creating better upward rotation of the scapula? They don't look at that. That's what people like me will look at to see where the biomechanical fault is that's creating the repetitive strain on the supraspinatus. So again, the idea is look at the patient instead of looking at the scan and going, oh, I have bursitis in my shoulder, or, oh, it hurts here in the front. Oh, I push on the bicep tendon. Oh, you got bicep tendonitis. We better inject it with a cortisone shot or whatever it.
In other words, labeling versus practicing precision foundational medicine.
Amen.
Which is exactly what we believe in.
Yeah. And if you can tell, if anybody knows me or been to me, or if you've been listening to this before, I'm a little fired up about this because it's not good for the patient. B, it creates challenging situations for me because I have to talk people out of what they have. As soon as they come into me, in their head, they have in their eye, in their little whatever they've looked up at Google or in their purview, it's, well, I have bicep tendonitis. Like I had a patient yesterday who he'd been to many therapists. He kept pointing at the posterior part of his deltoid. Okay, not the posterior delt, but the posterior fibers, the deltoid. He said, it hurts here and it's hurt here for months. And I said, okay, what have you been doing? Massage therapy, ultrasound, laser. Okay, so I had a professor years ago that said, he who treats at the site of pain is lost. Because the site of pain can be a referral from some other area. So, yeah, he was a little sore on that spot, but then I did a bunch of testing on him, and he had no stability in his external rotators. So your external rotators are the muscles that bring you up here. So he's having pain when he was doing anything overhead, like weightlifting or whatever, and it's because he couldn't stabilize his shoulder. So he's pressing. I put a weight in his hand, in his right hand, and I said, press it for me. Press it up and down, no problem. Put it in his left hand. I said, press it for me. And immediately his shoulder turned in like this, and he started pressing. So he's pressing on an angle like this, which was
no wonder that spot hurts.
Which was overloading the shoulder, which no wonder that spot hurt. But again, instead of going, symptom, fix it. It's let's look at the cause. So again, it's a labeling, right? And I want folks to remember your label is not your diagnosis.
Your symptom is not your diagnosis.
Thank you. That's probably a better way to say it. Symptom, label, diagnosis, no. If you go to the doctor and they say, oh, you have a rotator cuff issue. Now, if you've fallen off a ladder, okay, or if you slipped on ice and you fall in a certain way and you blow your rotator cuff and you can't lift your arm, and they MRI it and you've got a full breadth tear of your rotator cuff, we know the cause, okay? But I'm talking something that you've dealt with on and off, and you can mostly have decent function, but every time you play tennis or play with your kids or whatever, your shoulder hurts, and they say, oh, it's a rotator cuff. Ask them why. Ask them which rotator cuff muscle, because there's 4 of them, okay? There's not just one, there's 4. Say, which one is it and why? What's going on and how am I going to fix it, okay? Challenge them a little bit, and it may take them out of their comfort zone, but it's not that they don't care, but they're not equipped. So say, who can I go to get this fixed from a foundational standpoint? Okay?
I don't even know if they're going to know. It's really kind of sad, the state of healthcare. I continue to lose faith in the way that medicine is practiced, unless.
Well, listen to what you're saying, how medicine is practiced. What is medicine now? It's pharmaceutical medicine.
Yeah. I mean, it's all symptom relief and pharmaceuticals, to address the symptoms.
Right.
Whereas really what we're trying to get people to be as an advocate for their own health. It's sad that it has to be this way because you're going to the doctor and you think that's going to be your advocate for your health. The problem is they don't have the proper time to do it the right way. Therefore, people are going year to year stacking injuries that are not addressed properly.
Yeah.
I mean, yesterday alone, I saw 5 or 6 couples that I was like, I don't want to be like them when I'm that age, where they could barely walk to the car or to the bathroom, and they did not look that old.
I know, it's sad.
And so I just, again, it's all of our get better, not older stuff, meaning if you are properly diagnosed and we're using foundational precision medicine, meaning what is the cause? Let's go way back. Who cares about the symptom? Why is that way? And what type of testing can be done? Yours is a manual testing, whereas I'm doing more inside testing to find out what's your body trying to tell you. Something is wrong. This is just an outer manifestation of what's wrong. It's giving you a signal something's not right. Let's not just get a medicine to cover up the problem. Let's actually find out what your body's trying to tell you.
So I wanted to touch on a couple of more things, but this is a good segue. So inside out manifestation, okay? Rheumatoid arthritis. Okay, that's one. That there's a brand of medicine, or I shouldn't say brand, but a specialty called rheumatology. And rheumatologists diagnose things like rheumatoid arthritis, psoriatic arthritis, lupus, ankylosing spondylitis. These are all diseases of what they call the autoimmune, right?
Yes.
Meaning when you get a cold, the virus enters your body and your body goes, hey, foreign invader, and it creates a little army to attack the new foreign invader. After a few days, a week, you feel better, okay? With an autoimmune situation, something is being exposed inside or outside of your body, and your system is seeing it over and over and over, and your immune system on this autoimmune situation goes, I don't know what the invader is, so instead of creating an army that is designed to kill 10 things with, 20 attackers, I'm going to create 100,000 attackers to kill these 10 things. And then it doesn't recognize what to get. So what does it do? If it's rheumatoid arthritis, it goes to the joints. If it is psoriatic arthritis, it goes to the skin and causes lesions, but also can go to the joints. And so what do? We go to the doctor with these plaque lesions on our skin, which is, the psoriatic, flaky, itchy lesions, or you see on TV and you go, oh, look, yeah, they have that stuff too. Oh, I can take this medicine. Awesome. I'm going to feel better. Instead of going to somebody who does what? Well, there are tests. Right.
That we can find out why that autoimmune reaction is happening. That what that is just how it's manifesting.
Right.
But if we know how to properly test somebody's, let's just talk about the reality, their microbiome. Most often, that's where we can find the foundational reason that is that chronic inflammation has manifested in that way.
Right. So microbiome meaning the bacteria in the gut that we know more and more every year about that controls, mental health, physical health.
They've tied it to everything. But the thing is
health,
like
weight.
Everybody has to realize that it's the body's response and everybody is going to manifest in different ways.
Right.
And it's that chronic inflammation. It's what you and I have been talking about for our Get Better, Not Older, is trying to find out why are you inflamed, what's causing it, and then mitigating it if it needs to be mitigated, and then how do you live so that it does not control your life.
Right.
That's foundational health. That is integrative functional health.
Yep.
That is how we practice.
Okay. Now, getting back to kind of the spine model, I can't tell you how many people come in and wherever they've been referred from, online, other practitioners, whatever, and everybody's got an MRI to show me. Everybody that comes in with chronic low back pain. Well,
and it used to be you had to wait 6 months to get a MRI sometimes, or it wasn't the standard of care right out of the gates.
No, it is now. It is because they're cheap.
Yeah.
Which is good because, I mean, if you want an MRI, you can get cash pay MRIs, especially here in Florida, for like $250, $300. They're great. But everybody's coming in with an MRI. And I always say to people when they hand it to me, I always say, let's keep that on the side for a second because I want to examine you and see what I find, because I don't want that MRI to lead me down a path that may not be accurate with what's going on symptomatically. And I can't tell you how many times I've seen an MRI and let's say somebody presents with a left-sided problem in their back or their sciatica or whatever, and I look at the MRI and the right side looks way worse, or the report is way worse on the right side. If I followed that, it would match the clinical setting. So it just goes to show, we know that people are walking around with back issues that are asymptomatic, that if you look at the MRI, you'd go, ooh, that person's in bad shape. But because they're moving, because they're strong, because they're eating an anti-inflammatory diet, and they're doing the right things, they have no pain. And that's why it drives me nuts when people come in and say, oh, yeah, I have degenerative disc disease. Okay, how about our daughter's friend that was here for spring break last week? Mm-hmm. We're sitting on the beach, and she goes, Dr. Rob, you got to help me with my back. She's, how old is she, 21? Two. She said, I got diagnosed with degenerative disc disease when I was 17, and they told me I shouldn't run anymore. They told me I shouldn't swim anymore. I should never lift weights. So you're going to tell a 17-year-old who has quote-unquote degenerative disc disease. And I said, did they say severe? And she said, no, they said it was mild. Okay, so let's rewind. Anybody who's been athletic, once they get into their late teens, is going to show some degenerative change.
We probably should mention she was a gymnast.
She was a gymnast, but still, I mean, I've seen gymnasts. So anybody who's been athletic is going to show some breakdown in their spine. But again, just because it's a little bit broken down, it doesn't mean it's a death sentence. And to tell somebody, oh yeah, no more swimming and no more running and no more this and that, it's the worst advice you can give them. So basically what you're doing is you're saying, stop moving and be afraid to move. Now you're creating this situation. They're afraid of their back and they're labeled as, oh, I have a weak back. But you've not given them any strategies. Oh, and by the way, I asked her what she does. She was doing all the wrong strategies. So they label her, and then they don't tell her the foundational problem that's causing the back to break down. And what it was imbalance in exercise. She was doing, which I see a lot in youth sports, repetitive lumbar spine motion, which again, and here's another situation. You mentioned this earlier with Pilates instructors and massage therapists. We have coaches now because youth sports is monetized, and a friend back in Kansas City listened to a podcast, and I thought this was genius. He called it the youth sports industrial complex, which it really kind of is, and we've experienced it with both kids. You have cheer coaches, dance coaches, volleyball coaches, football coaches, baseball coaches, all across the board that know their sport really well, but think core work and strength is really important for said sport. But instead of bringing somebody in who's really qualified to teach that takes money from their own pocket, their own club's pocket, right? So they go on YouTube or whatever else, and they look up programs, or they say, we did this back in the 80s when I was an athlete. And they have them doing all this crazy backbreaker stuff that, my theory on this. And in this case, and hundreds of others that I've seen, it leads them to these back problems.
Yeah.
But she was never told, okay, this is your back problem. This is what we need to do now to get you out of pain. This is what we need to keep away from you, and this is what we need to introduce to keep you healthy. It was never given. Okay, she was given some physical therapy. She was given an injection in her lower back, which she said didn't help. And guess why the injection didn't help? Because they didn't stop the offending activity. It's like letting a scab form over a cut, and right before it's ready to fall off, you pull off the Band-Aid and scrape it off and it bleeds again. I mean, no wonder the shots don't work, because you're not stopping the offending activity. So again, the label of degenerative disc disease, or another one is stenosis. You know, a lot of these older folks come in with oh, I was told I have stenosis. Okay, well, stenosis is a narrowing of certain areas of the canals of the spine, okay? And it can be debilitating. So we've got a lot of older people that, especially here in Florida, that come in with stenosis, and it labels them, oh, you've got stenosis. You're screwed now. Good luck. You're not going to be able to ever walk again. Or if you do walk, it's going to be painful, and you should only do this. You should only do that. You should never lift weights again. And that's the thing that drives me nuts when I hear other professionals say to somebody, oh, you should never do this or lift that weight or whatever. So what? So we're just going to be weak, right? We're just going to succumb to this, and we're just never going to get out of the armchair again. Is that what we're going to do? Just like anything else, if you find the root cause, you can get stenosis better. And I've got case after case after case that I've gotten them better. You just have to know the right strategies to work with them. And if they're willing to put the work in, which they do, and I will guide them through, and I got patients all the time I tell you about where they couldn't barely make it into my office from their car because their sciatica was so bad from stenosis. And then I spent a couple weeks, maybe 6-7 treatments or less, teaching them how to do proper core work. The pressure comes off the nerve and they walk, and it changes their life. They become less depressed because they can finally get out of the house, go visit their friends, and go do social things, which we know social interaction is one of the most important things we do as we age, because without that, you're sitting at home depressed, and you might as well just put your foot in the coffin at that point.
Yeah.
So again, here's another label. Okay, so let me move on, and then I want you to talk about some stuff. Knee arthritis. Oh, yeah, I can't do that anymore because I have arthritis in my knee. Okay, you have a little arthritis in your knee. Well, guess what? So do I. And I still snowboard, and I still surf, and I still play tennis at a decent level. Now, does my knee never hurt? No. You see me do a lot of rehab at home before and after, but I can do most of what I want to do within reason. I'm not jumping off huge jumps on the mountain anymore like I used to do in my 20s. But I mean, yeah, I've got some arthritis in my knee, but what do? I make sure my biomechanics are good, and I make sure I'm strong. And you can mitigate 90% of those cases. It may not be 100% fixed, but you can function at 85, 90%. Now, there's cases, and my mother wouldn't mind me saying this, I'm sure, but remember she came to visit us in Kansas right before the pandemic. She said, Rob, you got to look at my knee. It's been really bad lately. And the first thing I do with a knee to test it is I test extension and I test flexion. Flexion is knee bend. She couldn't bend her knee 90 degrees, and it had a hard anchored stop, and that was bone on bone. And I was like, Mom, you need a knee replacement. I mean, and then, the Canadian system, a year and a half later, she got a knee replacement. Sorry, shameless plug against the Canadian system. But again, that's that label that will keep people psychologically from doing what they should be doing. Okay, and then the last one, plantar fasciitis or plantar's fasciitis, like they say on TV all the time. Do you have plantar's fasciitis? Well, you need to get shoes that have 6-inch cushions so you can really make your feet weaker and have horrible balance. That's one of the worst things I've ever seen is the recommendation of, oh, you have some foot pain. Let's take your little foot that's already crammed together and your toes are all crooked because you're old and you've got arthritis and plantar's fasciitis, okay? And then let's cram them into these Kleenex box shoes instead of putting them into something like a Palooza.
Kleenex box shoes?
Well, yeah, like think about, that's what Lisa said, which again, shout out to Lisa. I thought it was hilarious because she had them to walk around the clinic in.
You're talking about not the width, but you're talking about how...
Like the shoes like Hoka's or On Clouds that have massive soles.
Got it.
Okay, where you see these older people walking around on literally 3-inch cushioned heels.
I visualized walking around in blocks with your feet inside.
Well, that's what
Kleenex.
She said that I thought was hilarious because
with the Kleenex is gone out of them and you're using.
No. She said something hilarious because she was wearing them. I was like, what the heck is going on there? This is years ago when Hoka's first came out. She said, oh, I love these things because when I put my feet in them, I feel like I'm walking around in Kleenex boxes. Now, she did that at the end of the day when her feet were a little bit tired, but the majority of the day she was in like zero shoes or flat shoes to make sure her feet were strong. So nothing wrong with being in those type of Hoka shoes if you're going to be a runner or something. But if you have foot pain, you got to get those dogs out of the barn, get yourself some toe spreaders, and get your foot stronger. Okay. If your feet are all curled up, it's because You've got weakness. You've got to get them moving. You've got joints in your toes, like everywhere else in your body, that need to move through a range of motion. Here's something that most people don't know. We know a car needs motor oil, right? And when you start a cold car, maybe they don't experience this in Florida, but you start a cold car up in the Northeast or in Canada or whatever, the car goes, whoa, whoa, whoa. And then it slowly starts to kind of build back up as that oil becomes a little less sticky and syrupy. It starts to circulate through the pistons. So what is it? Is it a piston and a valve? No, cylinder and piston, right? I'm not a mechanic. Whatever that part of the car goes up and down, that's a piston? Okay. So it's got oil in it, so there's no friction in there. Our joints are the same thing. If we move our joints through a range of motion, we stimulate something called the synovial membrane, which stimulates synovial fluid, which is like motor oil for our joints. We don't move said joint because we've been told not to. Oh, you have arthritis. Don't move that joint. It's going to hurt that joint. Well, guess what? Now that joint is going to get stuck, sticky, and weak. You've got to move it to get the synovial fluid to move through it. And then guess what? Your tendons will loosen up. Your muscles will loosen up. And then guess what? Your plantar fasciitis. Sorry, I can't say that enough. Sorry. Everybody's an expert because nobody is. That's why I say it. It's plantar fasciitis. And really, incidentally, what plantar fasciitis means is plantar means the bottom of the foot, meaning the part of the foot that you plant. Fasciitis means inflammation of the fascia. The fascia very rarely gets inflamed. It gets tight, but there's other areas of the foot that become painful. It's usually the tendons being short. There's some data that shows there's an artery that gets crimped and the foot doesn't get blood supply. So we need to get our feet out of those tight shoes. So again, you've been told you have plantar fasciitis, and somebody has given you a shoe and a stiff orthotic to walk in, and now you're being supported by that stiff orthotic and instead of letting your toes spread and letting the muscles do what they're supposed to do, all you're doing is perpetuating a label, a symptom, and you're making it worse and worse and worse and making it chronic.
And that's really the purpose of this podcast, was so that you could educate our listeners on the fact that just because you've been told something does not mean it will dictate how you move or live.
100%. If somebody says you have plantar fasciitis, knee arthritis, hip arthritis, degenerative disc disease in your neck or back, ask them what you can do, who you can see to help you move better. Movement is always the answer.
Strength and movement.
Strength and movement. The only time movement is not the answer is if you have a fracture or a torn ligament and it needs to heal and you need to be casted or booted. Okay? Movement is the answer. And if somebody says, oh, you got plantar fasciitis, you should not walk, then you need to go find a different practitioner.
Yeah.
Because anybody who tells you not to move really needs to go to another profession, because movement's medicine. And I can tell you this clinically, it's helped thousands of people, but we know because of the human condition, we have to move. The less you move, the less you're going to move.
Yeah. Period.
The end. Okay. I need to ask you something that you see clinically, because I've monopolized this whole podcast, and I think I'm going to know the answer. What's one of the most common things that people will tell you that their doctor has labeled them with, or quote unquote diagnosed them with?
Yeah. I mean, we're going to wrap up this podcast, so I'll just say this quickly, because honestly, this would be for a lot of things. But IBS is probably one of the things I hear the most. And honestly...
And what does that stand for?
Inflammatory bowel disease.
Or irritable bowel.
Syndrome.
Syndrome. Oh, no.
Really what it is a trash diagnosis to say we really don't know what's wrong with you, but you're having these symptoms, so let's try this slew of medication to try to... And honestly, all it would take was me doing a GI map on somebody to see what's going on in their microbiome, and we would probably figure out exactly what's going on. I recently had a patient who was having some resistance to weight loss, and no matter what we tried, he was, everything that we went through, had been on the GLP-1s, was not losing weight. And I said, there's got to be a reason. So we started doing a bunch of testing. And mind you, none of these tests are covered on insurance. So this is more integrative care. We're talking here functional care.
But it's not really that expensive.
It's not. When it comes down to chasing symptoms that, and you're going to go and you're going to get biopsy, and you're going to get an MRI, and you're going to do this, and you're going to run these labs and these standard things for standard of care, and it's not really going to tell you still at a foundational level what the problem is.
And when you forgot colonoscopy, which is miserable, and then the medication, that's not going to work. When you look, even if you have insurance that it covers this, a lot of people don't want to pay somebody out of pocket because, well, I've got insurance anyways. Here's the thing. You're going to spend way more with insurance. Even if you've met your deductible, you're still going to spend hundreds, if not thousands of dollars on copays versus what does it get a GI map? $350?
Yeah.
Okay.
And so this person that was resistant to weight loss, we did a GI map, found out that he has a lot going on. He's got a strep overgrowth. He's got a staph overgrowth. He has H. pylori, like what we call dysbiosis, meaning there's an imbalance of good and bad bacteria in his microbiome.
Yep.
So because we now know that microbiome pretty much rules the roost when it comes to our health, clearly, if that's happening, talk about foundational medicine, that's what we need to address first.
Right.
Fix that, and then all of a sudden they start losing weight. Wow.
Yep.
Shocker.
And
then the other thing too is people come to me and then they'll talk about skin conditions, whether it's their face that they have this rash or they're breaking out or they have the psoriasis or whatever. That is your gut. That is your gut every time. And it's very interesting how people will be resistant to spend the money out of pocket on a GI map that could absolutely clear them up versus going to a dermatologist who's going to say, well, we don't really know what that is. Let's biopsy it. Shows nothing. Then they put them on a slew of medications to try to see if they can get it, whether it be a topical or something that they take by mouth. This happened with our own daughter. I told her it was going to be a waste of time, that they were not going to be able to tell her. And then as soon as we did the GI map and we cleared up her gut, guess what? Her face got better.
Yeah.
So I guess the takeaway here, and the inside out could be a whole nother podcast that we could talk about.
Yep.
But for foundational medicine, when it comes to internal, most everything, when you are having symptoms and a lot of autoimmune stuff, skin, resistance to weight loss, when you truly are doing everything you should be and not just trying to say that you are, but truly are, when, I'm guiding you through it and you're doing everything and it's not working, test your gut. It's called a GI map. We will have in the show notes an example of a GI map. You have to have a doctor order it, like you can order it for my patients. But find a good functional integrative medicine doctor who can test your gut properly. Even recently, I had a patient that went to a functional doctor, and I had already done all the genetic stuff and the GI map and everything and presented this doctor with that, and they didn't even address GI, didn't address the GI map at all, the results of the GI map. I said, well, then he doesn't know what he's doing.
Yeah.
Like, there is not going to be one true functional integrative medicine doctor who's going to look at the results of your GI map, which you could see how imbalanced it was, and not address that.
Yeah. If you go to somebody and they poo-poo that, you need to get rid of your doctor.
Poo-poo?
Poo-poo. Yeah, if they poo-poo the poo-poo, leave that in.
Okay, let's land the plane.
Okay, land the plane. But I want to say this again. If somebody is seeing a regular practitioner and they are dismissive of the integrative stuff and they only want to put you on medicine, I think it's time to find a new doctor, because we have a boatload of data showing that inside out, proper management, proper diagnosis, and not labeling is really the key to how you heal your body and live the best life you can and get better, not older.
And this is called precision medicine,
Yes.
meaning we're not talking symptoms. We are actually doing the tests that show you at a foundational level what your problem is, a genetic level what your problem is.
Yep.
That way it can be addressed properly versus wasting time and money on garbage diagnoses and expensive medications that are just masking the symptoms and not creating a solution for the problem. So, Dr. Jones, that was an informative podcast.
Thank you.
You got to talk a lot.
That's my favorite thing.
I know. This is your best day. So let's wrap it up.
All right. Well, lots of information. Inside out. Was that your stomach?
Yes, I'm hungry.
Wow. Time to get lunch. Lots of information. Inside out, outside in. So I think we're going to wrap up the GBNO show, episode 18. And again, I aptly labeled it or aptly titled it, Are You Being Diagnosed or Labeled? So maybe listen to this a second time because there's a lot of good information here. And if you see anything here that questions what's going on with you from the inside out or the outside in, you can reach out to us. You can ask us questions. We'll do our best to answer them. And then we can even direct you to somebody in your area. But anyways, so this is the end of the GBNO show, episode 18. Get better, not older.